Hello, I'm Dr. David Hornbrook. I think one of the most difficult and confusing things about dentistry is the subject of occlusion. I think we had a good education in occlusion in dental school, but it wasn't practical. When our patients sit down in our chair and we see occlusal disease or pathology, where do we go from that? And what can we do to not only provide our patient, I think, with better restorative dentistry, but to eliminate future problems with maybe dentistry that we place?
If we place these together into maximum intercuspation, we can see that the teeth meet up relatively well. However, in examples of destruction and examples of wear, this may not be the proper bite relationship for this patient. Another example is a Lucia jig. And how this works, as we see on the screen, is an anterior stop along with a whale's tail that allows the anterior stop to fit on the plane of occlusion. Again, this is good chair side, but one of the downsides is that the patient cannot, again, bring it home and wear that to bed at night.
Tap up and down. Open. No contact, so he is on that anterior ball. If I saw where maybe on a wisdom tooth or a second molar that he was starting to contact, I can actually adjust that out, do a little equilibration, it wouldn't be much, and then I'd let him sit for 10 or 15 more minutes, check it again, and sometimes that's all it takes.
We have great posterior stops in place. Now, up front here, we notice that the teeth are not in contact to our bite registration material, but that is because that the centric location appliance was in place there.
We saw Terry when we didn't have him deprogrammed, and I tried to take a bite, and I couldn't. Why? Because his brain, after all those years of biting down the exact same location, I was trying to put it somewhere else, and his brain said, no way. And we've all had that scenario in our own office. Once we deprogrammed, you saw how easy it was for him to have a very repeatable, very comfortable bite.